journal club discussion today. I will be discussing the topic silver diamide fluoride versus atraumatic restoration for managing dental caries in schools, a cluster randomized clinical trial published in 12th March 2025 in JAMA Network with an impact factor of 10.5. So coming to the terminologies that we should know before discussing the journal club is that ART, it is a method where the decayed parts are generally removed by hand instruments only and filled using a special cement, usually GIC, without using any drills or anesthesia involvement. And minimally invasive interactions, these are the treatments that fix the problems without drilling or removing the tooth structure as a whole conservative type of a treatment. So coming to the novelty, aims and objectives, this was one of the first long-term studies that was done for the duration of 4 years, school-based in the United States, New York, comparing two simple drill-free treatments for tooth decay in children. First of one is the SDF, silver diamide fluoride, and the second one ART. Which one is better? They wanted to carry it out through this research. It focuses on the real-world school settings with low-income minority children, making it very practical and community-based dentistry. And also they wanted to explore whether treating the posterior teeth with HGF could help prevent decay in the anterior teeth also, something not widely studied before in previous literatures. So coming to the aim of the study, to compare how well the SGF works over the ART in stopping the progress of decay in school children over a period of 4 years. The main objective was to see whether the SGF or ART, which is better at preventing the tooth decay from coming back or being repeated in already decayed teeth. Secondary objective was to check whether SGF applied to posterior teeth has a positive effect on the anterior teeth in the same child that was not directly treated. Additional goals were to understand the disease severity, that is how many number of teeth were affected, which affect the treatment success as a whole, and to compare how different races and genders respond to the treatment plan after the follow-up of 4 years. So the materials and methodology, it was a 4-year school-based clinical trial where the children aged between 5 to 13 received either SDF treatment or atraumatic treatment for the restoration of the carious tooth with ICDS scores of 5 and 6 and above, with treatments applied by aquadeep in both cases, and outcome tracked via visual exams based on ICDAS criteria. Statistical analysis, what parameters were compared, the number of tooth surfaces that were failed, which got caries again, recurrent caries after treatment, number of children who had at least one surface of the tooth that was failed. The risk of the repeated failure was also evaluated on the same or the other tooth surfaces. In total, 861 children received the silver diamide fluoride and 807 received atraumatic restorative treatment. So in total, 1168 children were incorporated into the study initially out of 7,418 after excluding the exclusion criteria. So what statistical tests were done? They had done the incidence rate ratio for comparing how often the recurrence of the caries was there in the SDF and the ART treated tooth surfaces over time. They also did the odds ratio to compare how likely each child had a failed treatment, whether it is in the SDF group falling or in the ART group falling. They also did the hazard ratio estimation to measure how fast the tooth decay returned back over a period of 4 years, and mixed effects and frailty models were used to adjust that children were grouped in school, and some children had more than one affected tooth which had either SDF treatment or ART treatment. So coming to the outcome, SDF had slightly fewer treatment failures than ART, especially when looking at children individually and not the surfaces over time. Also, when looking at the repeated failures over time, there was no major difference between SDF and ART. So coming to the results, when they compared according to the tooth surface for the surface level findings, 38% of the children had the teeth decayed again. In the ART group, 45% of the children, the teeth surfaces failed and the decay got recurrent. SDF worked slightly better, but the difference was not statistically significant. And when we look at the person level findings individually in children and not the surface level findings, 45.5% of children treated with SDF had at least one failed tooth that got decayed again, and 53.3% of children treated with ART had at least one failed tooth. So this difference was significant, showing SDF performed better over ART for individual children. And for the repeated decay or the recurrent failure, there was no major difference between the two treatment protocols. So coming to the conclusion, both SDF and ART worked well, but SDF showed slightly better results in preventing decay level at children, making it a good simple treatment for the children at the school settings. So coming to the strengths of the study, it was a real world setting conducted directly in schools, reflecting practical everyday conditions, not just in the clinical environment. It was having a large sample size. As I told, over 7,000 children were included into the study. After the exclusion criteria, 11,048 children were done across 48 schools, making the results reliable and widely applicable. Long-term follow-up period was there of 4 years at the school-based dental studies, and they targeted the low-income, blind Hispanic children, helping address health equity and access gaps for the public health procedures, and use of simple, low cost effective treatments which were minimally invasive were used, and also multiple statistical models, as I already told. It was used to ensure robust findings, and high training standards were maintained, and the examiners that they did the procedure were well trained, standardized, improving the accuracy and consistency of the findings. Coming to the limitations, because it was set up in the COVID era, several schools closed during the pandemic, so this can affect the gaps in the treatment and the follow-up, which may have affected the results as a whole. Missing data from lost teeth if the children age group was from 5 to 13 years. So if a baby tooth fell out, due to natural exfoliation, its outcome couldn't be tracked, leading to incomplete data. External dental treatments not done, whether these children were having treatment receiving from the dentist externally, this record was not being done. Blinding, because they had grouped the schools either into ART and SDF. So the schools knew who were having the SDF, and since SDF also leaves a black stain, the staff already knew which treatment was being used, so possibly introducing bias. And limited to surface counts and not severity. Findings not generalized to all populations. It was only for the low income age group, children in the New York. So it can be done in a future study in which all populations can be incorporated. So the type of study design, cluster randomized clinical trial, in which the whole schools were randomly assigned to one of the two treatment groups. It was conducted in a real world school setting. Also the trial was longitudinal for up to 4 years. So they had the checklist items according to the study. The title and the abstract was included, the background, methods, randomization, statistical methods, results, limitations, and funding was done. Only the blinding was not done. The blinding because they already knew the results, which group fell into which criteria. So blinding was only the limitation in this study. So coming to the future directions, the study the effect of the treatment frequency in the long-term results. Also analyze the tooth decay by severity. I had already told that it was only through the ICDS score. So single surface versus multiple surface deep caries or shallow caries can be done in future studies. assess cosmetic and social impact of SDF staining, how it will affect the quality of life of the children who receive the SDF treatment can be done in future studies. Explore indirect effects of SDF and expand to other populations, not only to the geographical locations where the socio-economic status was low. They can repeat the study in the high socio-economic groups also, combined with newer technologies or add-ons to test the SDF with potassium iodide also, and longer follow-up beyond 4 years can also be done. Thank you.